Hey folks, Scott Weingart here, one of the co-hosts for the One-to-One Resus Nursing podcast. In a moment, I will be joined by Candace King, my partner in crime on this podcast. Today, we're going to be talking about post-cardiac arrest care. This is critical. These patients are super sick, and there's so much to learn. So without further ado, let's get right into the show. Hey, Candace, welcome back to another episode of One-to-One Nursing.
How you doing?
I'm doing well. It's fall. I'm a happy man. Summer's finally dead.
It was very cold yesterday morning. Okay, I think I finally shut off my air conditioning. I wouldn't go as far as putting on the heat, but it's cold.
Yeah. In the Northeast, there's 3 days where you don't need air conditioning or heat. It's pretty much the transition goes right to. But we're not going to primarily be talking about the weather today. What we're going to be talking about is post-cardiac arrest care for the resus nurse. Last time we did cardiac arrest, so it makes logical sense to go to post-cardiac arrest. And I think this is an area where, at least from the hospitals I have experience with, the nurses are not given enough education on how to take care of these patients. They're just thrown to the wolves and allowed to deal with. Some hospitals might have protocols, and that's good because that will guide a lot of this stuff. But that I just don't think it's discussed to the extent it should be. And that's sad because these are the sickest patients in the hospital in almost every case. And we'll talk about reasons why. Candace, at your shop, they have post-arrest protocols. Is that right?
Yes, I have a nursing standard of care for the management of post-arrest and TTM guidelines.
Fantastic. All right. So you have a patient, either they were brought in post-arrest, which happens sometimes, or you guys successfully resuscitated a patient from cardiac arrest. And the first thing I want to have on the nurse's mind is that you're certainly not out of the water when these patients get ROSC. And in fact, it's a really dangerous time because there's usually this honeymoon period where the epi it's still percolating through their system and their blood pressure is great. It might even be high. And you're like, oh, wow, look at that blood pressure, 160 over. But that period lasts a brief period of time, 5-10 minutes. And then they plummet because all of that insane dosing of epi wears off. So I would say have norepi in the room the second you get a post-arrest. Now, at your shop, they usually had norepi there during the arrest. But if you don't, now's the time. Call for norepi, have it there, because you want to be able to hook it up and start it immediately when that patient's blood pressure starts fading. And then the next part of stabilization, I think early on, is to get a 12-lead EKG, because if these patients are going to be a cath lab activation, getting that as soon as possible is actually saving heart.
I think that should be, as we talked about last time, the nurse code leader, right? So once I find a perfusing rhythm and I say, does anyone palpate a pulse? If the answer is yes, I immediately ask them to shoot a 12 lead, right? So there's opportunity for you to put on your 12 lead cables during the arrest. You should take that opportunity. You're not losing any minutes. You can activate your cath team as quickly as possible post-arrest. That's your opportunity to really capitalize on lost minutes.
Absolutely. That's a fantastic point. And at Candace's shop, they actually have 12 leads at every single resus monitor that you don't need a separate machine. And this was a real eye-opener for me where I'm used to having to call for someone to bring a 12-lead machine and do it. So it's a lot easier for you to have these things just hooked up than it might be for other people where they're not going to have that 12-lead machine sitting there. Now, there is one little wrinkle to this, which is sometimes just the post-arrest state in those first few minutes will cause what looks like ST elevations or severe depressions and other stuff that really fades away 5 minutes later. So if sometimes you see a classic OMI, an occlusion MI, which is our new term for what used to be called STEMI, you'll see it. It's just so obvious and you'll get cardiology involved. But even as they're coming down 4 or 5 minutes later, shoot a second one. And sometimes what you'll see is complete normalization, or it goes from what looks like a horrible STEMI to just some T-wave inversions that you're still going to have your eyes open for, but they're no longer a cath lab trip. And I personally don't mind bringing the cardiology fellow down there and saying, hey, the first one looked horrible, but the second one looks fine. And they're like, oh, okay, we'll watch this patient. That's fine. It's better to have them down there and ready for if the second one is horrible. But just never send a patient to the lab based on just one EKG, because there is this period immediately post-arrest where they have horrible looking stuff that then completely disappears soon afterwards.
Yeah, and I think that's the reason why if you have the opportunity to have hardwired 12 lead cables. For me, I'm not a huge fan of the portable machine because I feel like those little stickers, especially if the person's like sweaty, they don't stay right.
Yep.
That's why I always had the cables on in all of our recess monitors. For the
Totally agree.
extra purchase was worth it.
Yeah, for sure. All right. Now, I've mentioned these are the sickest patients in the hospital. And the reason why is because post-arrest and this entire syndrome really hits multiple systems. So these patients have a brain injury just from the ischemic time of the arrest. They have myocardial dysfunction. The ischemia hits the heart really badly for the first 2 to 3 days. And they have SIRS response, massive sepsis-like syndrome of vasodilation and inflammatory markers, and then whatever underlying pathology caused the arrest. So they really are being hit on all sides, and that's why these patients are so sick. And it brings to mind a question that a system and an individual nurse should be asking and having discussion with their doc partner for this patient, which is, are we really the best hospital to be managing these patients for the long term? And look, if you're at a center that has cardiac cath and aggressive mechanical circulatory support, then yes, the answer is right. And Candace's shop certainly fits the bill on that. But many of these smaller centers that have ICUs, that might even have cardiac ICUs, still are not the best placed for a viable post-arrest. Now, you take a 85-year-old patient from the nursing home, right? And they don't have advanced directives, but their protoplasm is such, they're not going to have great odds of survivability neurologically intact anyway. And they're not really going to be eligible for all these mechanical circulatory supports and aggressive therapies. So keeping those patients, I think, is okay. But even though your hospital is going to lose some revenue, the best thing for the patient, if they're like a 65-year-old and they had a normal status beforehand, is to transfer to what is slowly being called these cardiac arrest centers. And we have trauma centers, we have stroke centers, and what we really need is cardiac arrest centers that have the full bevy of neuroprognostication, cardiac interventions. The possibility of LVADs is a nice thing, though not necessary. That could be a transfer. But all of these things go into a center that is going to be the best place for cardiac arrest. So if you're a community shop and you don't have any of these, transferring these patients would be the right thing, even though the hospital's administration may say, oh, no, keep them. We have an ICU. There's no reason we can't keep them. We have an ICU. No, an ICU is not enough. You need all this other stuff. Now, Candace, you are now part of a system. Are you guys actively urging your smaller hospitals in your system to transfer to the big center?
I think we use guidelines similar to what you said, right? One of the sister hospitals has a cath lab. They have the ability to put in an impella and a balloon, but they do not keep that patient, right? If their thought process is this is an occlusion and that's what we think is the source of the cardiac arrest, they'll take them to the lab and they'll put in an impella and then Candace comes and picks them up. Like literally Candace comes and picks them up, right? And then the other sister hospitals, they don't have cath labs, right? So they transfer their post-arrests pretty much immediately out of the ED. If it's an elderly patient where the prognosis is pretty poor, we typically don't get those. They'll keep them in their ICU because they'll wait a couple days, and if there's a need, they'll transfer them at that point.
Yeah.
But I think it's looking at the picture overall to make the best plan.
That makes complete sense. All right. Now, let's talk nursing ratios. Immediately post-arrest, ideally, you'll have a swarm of nurses there. There's a lot to do. But then as things start to settle down, in the ICU, especially if these patients are getting hypothermic management, there'll be 2 nurses to 1 patient. That's how much nursing work there is. And that will never happen in the ED. But you folks, I think in general, try to get 1-to-1 nursing and at most 1-to-2, which is not possible in many of the centers that we're going to be speaking, the nurses that are listening to this right now. Candace, if you were at one of these hospitals where they don't have the nursing ratios, what kind of thing would you say is the absolute minimum for these patients?
I think 1-to-2, to be honest. If you're using the Arctic Sun and following all the guidelines in the standard of care, you have too much work and not enough time. But So I think that there's opportunity to take another patient. Definitely wouldn't suggest that it be like a post-thrombolytic patient or somebody that needs equal amounts of time, but you can definitely have a high acuity patient that you can visit 2 to 4 times an hour, that you're not in there doing aggressive management for. They've settled off. I think you could keep that. Obviously, ideally, it's 1-to-1. That never happens downstairs, right? In anywhere, my place, anywhere else. And you're 100% right. Super lucky that I have that lead nurse to fill in there, or I'll pull myself to fill in there when it gives that opportunity of relief to the other patients. And I do believe in team-based approach, right? So I can pick up something to help my colleague depending on what the workload is.
Now, this speaks to what my buddy Sarah Krager calls the difference between proactive and reactive nursing. And this really is an understanding. This is like a real tenet of this show, is that you could feel you're doing a good job reactively on these patients with lower nursing ratios, because you'll pop in, you'll see the blood pressure's drifted down a little bit, you'll fix it. That's reactive nursing. And you could do what looks like pretty good care that way. But the problem is these patients don't tolerate those and we're not talking they drop down to 30 and you had to rescue them from that. We're talking they drop down to 60 from the 65 that you consider an absolute bedrock minimum. And you're like, yeah, no problem. We'll just raise the norepi now. But that might be a problem in a cardiac arrest patient who has now been post-arrest versus a septic patient. They probably tolerate that fine. And that's why cardiac arrest and post really requires proactive nursing, like a nurse who's at the bedside for a good portion of that hour, such that that gets found immediately and not 20 minutes later. And that's why the nursing ratios are so important on these patients. And I think if I was going to write regulations for cardiac arrest centers, that would be one of the things I demand is 1-to-1 nursing in even the ED. And most hospitals say, we can't do that. Then guess what? You're not a cardiac arrest center anymore. And we just won't take patients to you for cardiac arrest and post-arrest care. And then all of a sudden, oh, wow, like magic, the administration would make it possible to do 1-to-1 nursing for these patients. So that's really what it comes down to. All right. The next thing I want in the mind of the nurse taking care of this patient is, why the hell did they arrest? And that's going to be a through line throughout the entire thing. You're not necessarily going to find it in the first 10 minutes, but the thinking should be in the first 10 minutes, what caused this arrest? And, you're going to do the ECG, it was mentioned. Doc is hopefully going to do an echo. You're going to get labs, blood gases, and we're going to talk in a bit. You're going to want pretty early on to go to the CT scanner, because unless you found an etiology, you got to keep searching for it, because something made this patient arrest. Now, it could be something like a dysrhythmia that you're just not going to have evidence on early on, and that's fine because you've ruled out all the other things that you could possibly actually intervene on. But that process of elimination has to happen early on. All right, Candace, so let's go into blood pressure and hemodynamics. These patients should, if you're transferring, then maybe you defer it to wherever you're sending them. But if you're keeping these patients, they should get an arterial line. You should not be managing the blood pressure on a post-arrest patient with a non-invasive cuff. And I like to place these, if I can, centrally, meaning either in the fem or the axillary, just because these are super sick patients and those give more accurate blood pressure representations. If all you could get to radial, that's all the doc could do, that's fine. They should get central lines at some point. You don't need it immediately, but pretty soon on. And then let's talk MAP goals, Candace, because this is different than even what I would have told you a few years ago. So the current recommendation from the American Heart Association and the Neurocritical Care Society, those two got together and did joint guidelines, is a MAP of 80. Now, this is a sea change from what we were used to. Everything's MAP of 65 everywhere. And 65 is still considered a okay bare minimum. But we've been talking for a decade now about the concept of pushing the MAP in these post-arrest patients. And the reason why, it's purely neurological. They get this, what's called no-flow state. They get these areas of their cerebral vasculature that are blocked. And it's just not going to get blood flow. But if you pump up the amount of the pressure head, you can actually force flow to these areas. So it's an attempt to minimize the actual amount of neurologic damage. So pushing the MAP to 80 with vasopressors, these patients almost always are not fluid down, so fluids don't take a big role here unless it was a hypovolemic arrest. So really pushing with vasopressors their blood pressure up. Now, norepi, it's a great standby, and if you just use, that's fine. In general, I usually will slip in some vasopressin if my norepi doses are getting pretty high, but not super high. Like at 10, I'll say, maybe a balanced resuscitation here of vaso and norepi makes a lot of sense. Anything to add to that, Candace? I bet the 80 is a difference from what you've been hearing up till now. Is that right?
Yeah, we usually stick to 65 to 70, but it makes sense, right? Because you want to overflow the brain. My only thing is, one, we talked last time, we should really strive to have A-lines during resuscitation, and central access is regular for me. So I don't know what it's like to not have a central access. And then maybe that's because I'm in a teaching institution, gives residents an opportunity to really hone their skills. But I agree with that. I think that we do not put vasopressin on early enough, and it's something to think about, right? We usually wait till the norepis at 30, and it's like you're not going to see a huge change in the numbers hemodynamically for like the measures for the nurse by adding vasopressin, believe it or not. I say sometimes you see no change or very minimal on your monitor. Totally agree about the fluids. Like you don't need liters and liters of fluid. If anything, then you're chasing electrolytes that you don't want to do afterwards. And everything that you give is in volume, right? So it just grows to a huge amount of volume. And maybe 10 years ago, we gave 7 liters of fluid, but that's definitely not what we've done in the last decade.
I love it. All right. So hopefully early on, your doc is going to do an echo. And based on that, we'll determine whether the patient also is going to benefit from some inotropes. I personally prefer low dose, cardiac dose epinephrine. If your shop uses dobutamine, that's fine too. But epinephrine, I think, is that combo, norepi and epi, is just gorgeous together. Controversial area, Candace, is steroids. Now, some would advocate empiric steroids post-arrest, and there's some data for that. We generally wait till we're on higher doses of norepi, and we'll add steroids at that point rather than just putting them empirically. And we're talking 50 of hydrocortisone, 100 of hydrocortisone, something along those lines, just like we would for a septic patient. And that will really, I think, fall down to your hospital's individual protocols. Now, one area that people are not thinking of enough for patients who are hemodynamically unstable is ECMO. And we have started really pushing for ECMO during CPR. That's the entire eCPR movement. But there are patients who they get their ROSC and you look at them and now they're on 30 of norepi and vaso and you're like, all right, they're okay. Their MAP's 68. That patient has a high chance of rearresting because of this post-cardiac arrest syndrome. And if you get them through the first 72 hours, they get off the pump. And it depends on how aggressive your shop is. But if you are a shop that has ECMO, it's definitely something to just have in the back of your mind. Is really now we're up on 50 of norepi. Is this the best way? Because we know once we get them on pump, they're going to be protected for the next 3 days. Their cardiac stunning stops. Everything gets better. And then that's a survivable patient. And I really believe most of the benefits of eCPR during arrest is actually taking place because they're protected in this post-arrest period versus the magic of it during the cardiac arrest itself.
Yeah, I would agree with that.
Let's talk ventilator stuff. Vent settings, we're going to go relatively low tidal volume. I'll generally still start these patients on 8 mLs per kg and then just monitor their plateau pressure. Some shops are going down to 6 empirically. I don't think the data is really there for that, but the guideline recommendations are 4 to 8. So as long as you're not being overexuberant, you're fine. Now, what is really a nursing thing are your oxygen and carbon dioxide goals. And what you don't want is the patient sitting at a saturation of 100%. That's too much, nor do you want them low. So the range that's in the AHA guidelines, 92 to 98%. And that 98 is really nice because that tells you that they're not hyperoxic, right? You don't want to see that 100, 99 even I'd take. What you don't want to see is 100 because 100 could be right at 100 millimeters of mercury on your blood gas, or it could be 500. You don't know. At 99, you know that they're right on that border of a happy place. They're at that upper border. If they're 92%, they're at the lower border of that happy place. So that's a really nice range to keep in mind. CO2, we're shooting for 35 to 45 on a blood gas, either venous or arterial is fine. People ask, can I use end-tidal CO2 for that? And the thing is, if it's high, you have a problem, and you should ask the respiratory therapist to go up on the respiratory rate. But if it's in the normal range or low, you can't make any determination because the way it works is the actual blood gas CO2 is always at least as high as the end tidal. Meaning, you have an end tidal of 35, the blood gas could be 35, it could be 50, it could be 100. You don't know. So all you could say is if the end tidal is 50, they need to go up on their respiratory rate. If the end tidal is 20, you don't know. You need to that should tell you I need a blood gas because there's all sorts of things in the lungs, shunt, VQ mismatching, perfusion. All of these lead to a discrepancy between the end tidal and the blood gas. So all you could say is that the real blood gas CO2 is at least as high as whatever number on the end tidal.
Yeah, and I think advocating for point of care testing, again, gives you that opportunity. You don't need 7 or 8 devices like me. You can do it just fine with one and then just have multiple cartridges. That will give you the advantage of having that early. I think it goes back to you have an ART line as part of your standard post-resuscitative care. It takes no effort for you to draw that gas.
Absolutely. All right, let's talk pneumonia protection. So you want to nurse these patients head of bed up, both for the pneumonia perspective and because it's potentially going to reduce intracranial pressure, and everything just works better with the patient in a natural position. Supine is never natural. No one should be nursed supine unless there's something very specific going on. Inline suction, hopefully respiratory is placing it. In many places, they won't unless you ask them. At your place, you have them available. You could just put them on yourself. Some places, they don't. Intermittently, like sticking a suction catheter down there and disconnecting their vent and losing their PEEP, that's prehistoric. It shouldn't be happening. But then you actually got to suction them. You should be coming by. Now, in some places, respiratory is going to handle that pulmonary toilet. But if not, then you should be doing it. Like every half hour, you should be suctioning that patient and making sure they're clear. Controversial area is empiric antibiotics. There was one study showing, a randomized controlled trial showing that Unison actually helped these patients from a post-cardiac arrest pneumonia perspective. It hasn't shown any patient-important outcomes, and the guidelines are like, consider it, but don't empirically give it to everyone. And if you're going to consider it, the patients to give it to are if you're actually in... Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Reducing hypothermia, that's one consideration that makes it more beneficial potentially. And the other one is they aspirated during the arrest.
Okay, that makes sense.
Yeah, lungs full of crap and hypothermia, you probably should give some empiric ampicillin subactam or ceftriaxone for 48 hours. Or if they didn't do those two things, then I'd probably hold off, is what my current recs are. But obviously your hospital might have an individual protocol. Are you guys giving arrest antibiotics, Candace?
We will give ceftriaxone.
Are you guys empirically giving ceftriaxone to everyone, or is it a case-by-case thing?
I would say the older population, yes. Younger population, no. 70 years of age is our cutoff, probably, I would use. The older population, yeah.
Let's talk sedation. Now, if your patient's GCS3, they're not reactive to anything, then you don't need anything. You don't need a sedative. You don't need an analgesic. Now, obviously, if they have an increased level of reactivity, then you're going to have to give stuff accordingly. What you don't want is anything that accumulates. So propofol is a great choice. If they need an analgesic, then as little as you get away with something that doesn't accumulate. Potentially even intermittent boluses may serve you better in these patients than a drip, simply because you're not going to have the continuous accumulation. And that accumulation is what leads to potential delayed wake up. Their metabolism is wonky. It takes a long time. And all of a sudden, the patient who would have woken up on day 2 wakes up on day 7. So it's just something to consider. You will just obviously give what's necessary to keep a patient comfortable, but not anything more than that. Everything's different if they're on a hypothermia protocol, because then those analgesics are actually part of a shivering protocol, and we'll talk about that momentarily. All right, CT scan. Early on, this should already be in your mind the second the patient's post-arrest is when is a safe time to go to CT. And you don't want to do it when their MAP's low and you're still getting them all lined up. But you also don't want to wait 4 hours, because if they have something reversible that you could have intervened on, it would be really sad not to get it early on. So taking that trip, usually within the first hour, but it's a pain in the butt is what it comes down to. So that you have to really prioritize this. This is where like the task management of a good resus nurse really comes into play, because the docs, they're not necessarily the best ones to make this decision. They're like, let's go to CT scan. And you're like, no, there's a lot of things we need to do first. So it's really going to be a nursing decision in many cases. Now, obviously, if the doc does an ultrasound and I think this is a dissection, that changes everything. And now, but we're talking about a patient who's, undifferentiated, but they still need the trip. And the other thing to go to CT, it'll tell you possibly an etiology of arrest, but the other thing is you'll find a lot of injuries from the arrest management itself. You'll find broken ribs, you'll find liver lax, you'll find spleen lax, pneumothoraces, et cetera. So for both of those reasons, it's worth getting the CT scan. And the CT you ideally want is you want a head. Probably could do a C-spine. I don't think the C-spine risk is really that high. You're there, so generally you'll do that. But the real key is getting a triple scan of the chest, which means pulmonary embolism, dissection, and coronary artery CT. And that latter one really requires a really high generation scanner. You want the most modern ones possible. The older ones, they're just not quick enough to get it within one heartbeat. But the newer ones, the 320s, maybe the 160s, you could do this even in a patient who is not bradycardic. You're obviously not going to be giving beta blockers to these patients post-arrest, but they could capture it. And now all of a sudden, even though the EKG did not show a clear OMI or STEMI in the old parlance, you'll still find they have a 95% LAD lesion, and that patient's going to take a trip to the cath lab. So this could be a real game changer, and there is a randomized controlled trial on this. And so that is what I do on the chest. You'll find PE, you'll find dissection, you'll find coronary blockages, and then you follow through to the abdomen and pelvis to look for CPR injuries or other stuff that might have caused the arrest. And so that scan is going to be a real game changer. Now, if it hasn't happened and the patient's going up to the ICU, it should happen on that transport between the ED and the ICU. And that, look, if they have an ICU bed and the patient's going to go up within 2 hours or 90 minutes from their arrival, and you're like, I could go now, or I could wait 20 minutes and just go in one shot, CT and then ICU, then that might be the better way to go.
I have no idea what it's like to have a timely ICU bed, so that doesn't happen for me. But what I will say, because I'm a nurse, right, and you're a doctor, we think differently. I like to go to CAT scan before I put the Arctic Sun on.
Oh, yeah.
Because that's why people don't want to go to CAT scan. It is a pain to haul all that stuff, and you're so likely to pull something out. Pull out a line, pull out your art line, whatever you're doing. And just so many cords and wires. So for me, post-arrest, the first thing I do is say, somebody call the scanner and find out when I can get in there, right? Depending on who's on deck outside the scanner to begin with. And then 2, I would like to move the patient. And then when I return to the recess room, I will put on the Arctic Sun pads. So that's the thought process for me. As far as movement of the patient, so I capitalize on going to CAT scan as soon as my blood pressure has become like a little steady state and before I put on the Arctic Sun.
That's brilliant. I love it. Let's talk about temperature control. That's next up on the list. So it's perfect to follow that comment, because then we might get into some disagreement where I think, I don't know if the Arctic Sun should really be involved anymore, but we'll talk about that momentarily. Before we get to that point, we have to figure out how we're going to monitor temperature. And so you need a monitoring device. You can't just do intermittent temperatures. Now, I have spoken to docs and nurses at hospitals where they're still doing rectal probes. Oh. Don't do that. That is A, not accurate, and B, a real pain in the ass, no pun intended. It's not good. Stop doing that. Now, every rectal probe is also an esophageal probe. They're all made for both. They're basically the same kind of place. It's just a different stuff that hangs out there. And so if you don't have Foley temperature monitoring, urinary bladder temperature monitoring, then use an esophageal probe. And in general, the doc's going to have to place these but it's not hard to do, though they're very flimsy. So there is a trick. I'll put a video there. You can actually drop a split endotracheal tube down the esophagus, drop your esophageal probe to the right where the heart is, just an inch or two above the xiphoid process. And then you could pull the endotracheal tube out. And since it's slit all the way down, just pull it off the temperature probe. The video will make complete sense. Candace is looking at me skeptically. Okay. But this is a way to get it down there. And that works just the same machines that you'd monitor with the rectal probe, you now can monitor with the esophageal probe. And that is accurate. It's probably the most accurate of the non-invasive techniques. Now, much cleaner and easier is just to place a temp sensing Foley. And you probably should have these at your institution. So getting those is great, but then they don't work unless you have the cables. And this is like a huge source of discontent for every ED resus nurse out there is cable management, because finding Artline cables and boxes, finding temperature probe cables and boxes at some places is this enormously painful process that shouldn't be. Like, this should be a hospital systems level solution to all of this that shouldn't involve the resus nurse ever having to look for this stuff. But Candace, even at your shop, this ivory tower on a hill, you still have to deal with these same issues, right?
Yes. My ICU colleagues, they're hoarders. They hoard pump channels. They hoard all of the A-line cables. They hoard everything up there. It's amazing when you go in their stockroom. I literally went to the candy shop. I don't understand. In the ED, we're like the poor folk that don't have A-line clamps. We use tourniquets that we've put through the side and now attached it to the patient's arm. They have all these fancy clips, and it's just totally different, right? We're fine being the poor show with tourniquets, and they want fancy new stuff. Thankfully, I have an amazing relationship with my colleague who manages the medical intensive care unit. So she sends me things like, it's my birthday every month, right? She's like, I'm going to come visit. And that means I'm getting a bag of supplies. But I definitely do make it everybody's responsibility to ensure those are there on the day shift. For me, my volume, we've talked about this before, it's very low in the morning when people come and very busy at night. So that's the responsibility of the day team. When I walk around with my morning coffee rounds, I have no problem calling you out on you sitting at the desk doing nothing, and I notice there's no A-line bags made. And if you think I didn't open those drawers before I came to you, that's a sad mistaken on your part, right? I know what's happening before I say something. So when they see me coming with the coffee, then they know I better make sure that stuff's done. And I think that helps. But certainly that is everywhere you go.
Yep.
But you got to go to the candy shop, which is up in your ICU. It's amazing what they got in there.
Oh, man. Yep, those hoarders. All right. Now, if you don't have on your monitors temp boxes, then get a hypothermia machine in the room, even if you're not going to use it, and then use that to monitor the temp. You need something that's going to give you a readout of continuous temperature on these patients. And that brings us to the next topic, which is the temperature goal. What is inarguable is that you cannot let these patients get febrile. That is the absolute. Whether you're going to do hypothermia or not, they can't be allowed to get febrile. So you must have continuous temp monitoring in there and be checking it on a constant basis to make sure that they're not spiking, because fever is really bad for an ischemic brain. So you don't want that at all. Now, in terms of temperature goal, you really have two choices. My choice in any place where I have the determination is normothermia at this point. Further studies may change that. That's 37. We don't want them to be 38 or above is absolutely forbidden. So 37, very nice place to be. I'll happily take them if they drift down above 36, but I'm not shooting for that. So we call that normothermia. The other option is induced moderate hypothermia, 32 to 34. Now, either of those, I think, are acceptable, and that's what the AHA says. What isn't acceptable in my mind, though the AHA still says it's okay, but it just makes no sense, it's 36. And that 36 came from Nicholas Nielsen's study, where he compared 32 to 34 versus 36. He never wanted to do that. That was forced on him by the IRBs. He picked 36 because they wouldn't let him do the study he wanted to do, which was normothermia at that point. He did that study next. So 36 was just a stopgap measure. Nothing good lives at 36. You get none of the benefits or putative benefits of hypothermia, but your life becomes miserable because they'll have incredible shivering at 36. In fact, more shivering at 36 than at 33. So don't do it. There's no gain to 36. It's all pain, no gain. So either actually go for the hypothermia and have potential benefits, or go for the normothermia and make your life easy from a sedation and shivering perspective, but don't do 36. Candace, are you guys still at 32 to 34? I know you were in a study protocol at some point.
Yes, we are in a study protocol. 32 to 34 needs to happen within 4 hours. It is extremely difficult to do.
Yeah.
Very difficult to do. That's definitely it's from a nursing standpoint, you're really just chasing the patient. You're chasing the temperature. If we're not enrolling the patient in the study, then we go to 36.5 is the lowest, right? At 36.5, we get concerned. At 37.1, we give Tylenol, right? 37.1 is Tylenol. So anything greater than 37, so 37.1, you should be giving Tylenol right away.
Again, I like normothermia, but if you're doing hypothermia, then a few things have to happen. One, you need a good machine. A lot of these hospitals have Blanketrols. They're not sufficient. I've worked with them. I've worked with all of them. I've tested them all. The Blanketrols are not good enough. Case Polderman's work will bear this out. If all you have is a Blanketrol, then do not use the pads like they are told to by the manufacturer, where you put one underneath and one on top. There's just so little skin surface contact on that. If you're going to use them, what we worked out is you have to burrito wrap them. So you have to take one of the pads and wrap them on their trunk, their torso, and tape that shut. So now you have circumferential skin contact. And then you need to put another pad on the legs. If you could have, they sometimes have smaller pads. You could wrap one around one thigh and one around the other. Now you actually have 3 tubes. Some of them only have 2 orifices. So then you grab another burrito wrap around both thighs and tape that up so that you have circumferential on as much of the body surface area as possible. I've had nurses tell me that these pads can't touch the skin on these Blanketrols, and they will put sheets on the patient and then put the Blanketrol. That doesn't work. That insulates the patient. They're made to touch the skin. But the Blanketrol for an induced hypothermia protocol is really insufficient. So you either want Arctic Sun, and the reason I specifically call out a manufacturer is, as far as I know, they are the only ones with the gel interface pads at this stage. If another one happens, then I'll just say gel interface-based pad-based machines, and those obviously touch the skin. Or you want an invasive catheter system, and either of those will work pretty well. But you need something. Then you need a shivering protocol. And you need to have the nurses, without having to go to the doc, be able to escalate that shivering protocol, because you rapidly lose their hypothermia otherwise. If they shiver for 10 minutes, they've raised their temp significantly. And so you need that. We're not going to discuss that extensively. And then you need a sedation protocol based on hypothermia, which means they are probably going to be getting aggressive fentanyl and propofol, and then all sorts of other stuff added on auxiliarily to manage their shivering. So is that what you're doing, Candace?
Yeah, same thing. We use the Arctic Sun. What I could say about the Arctic Sun is there's different sizes of pads. It's not one size fits all. You need to read the weight requirements on the pads. And then there's an abdominal pad, right? For people that are taller, longer, you often need to use that. Or if you got a little extra in the front, you need to use that pad, because you're defeating the purpose if you're not really cooling them significantly. So for me, you got to read the size. One size does not fit all, and most of the population needs the abdominal pad. Tall gentlemen or people with a little extra in the front. There you go.
All right. Now, if you're doing normothermia, the problem with this is that people get lax. They don't consider it targeted temperature management. Normothermia is still targeted temperature management. You're still trying to keep these patients in an incredibly tight range. And so that requires a couple things. Now, Candace mentioned that at 37.1, they'll add on antipyretics empirically. I would say, for me, just give them, like, even if the patient's 36.5, because they won't hurt anything, but they will blunt the inflammatory response. So scheduled antipyretics make complete sense to me. They won't make hypothermia worse, so there's no reason not to give them empirically. So you could just give your Tylenol around the clock. The other thing I want is for people to have, as soon as they have a post-arrest patient and they're going down a normothermia pathway, they call for a machine and the pads that are appropriate to that patient's size to be brought to the bedside. Don't open the pads. They're very expensive for something like an Arctic Sun, but don't now have to call to the stockroom to get them when the patient spikes a temp. So I would like to see an Arctic Sun or whatever machine you're going to be using and the pads brought to the bedside at the time you start your normothermia protocol. And doing that will eliminate delays and remind everyone that it's not okay for them to have 38.1. Oh, 38.1 is not a big deal. That's not a high fever. For these patients, it's a big deal. And I personally don't use invasive catheters for normothermia maintenance. I think we can get the job done non-invasively. I know some centers are doing that. And look, if the patient started spiking 102 temps and I can't get them down with the pads, then yes, invasive hypothermia makes a lot of sense. But for most part, something like an Arctic Sun, you could do the job quite nicely.
We centralized our Arctic Suns, right? So we always have pads on the unit, just not the machine, because again, warding, right? Like I told you before, once the patient gets ROS, the pads go on the patient. Patient goes to CAT scan. By the time they come back from CAT scan, the machine was brought up from the basement. Then you can just attach it. And you're not wasting time looking for pads, the sizes, the this, the that. It's already on. So even if the patient's normothermic, we still put the pads on because at some point they tend to run a little bit of a high if you're not managing their shivering appropriately. So we just use the Arctic Sun if we're doing post-resuscitative care.
Love it. All right. There's another little wrinkle here, which is the patient, you're on a normothermia protocol, or that's your goal temp is normothermia. But the patient, because of their arrest time and they were exposed a lot with EMS and maybe it was cold out, they are hypothermic. And the natural tendency is to just, they'll get to where they need to go as they rewarm themselves. That's not great. Now, we don't have fantastic evidence on this. This evidence is extrapolated from the patients we kept hypothermic for 24 hours. But the current recs in most places, most guidelines, is to do machine rewarming on those patients from whatever they're at. Let's say they're at 35 up to the 37. And you do that slowly. So a quarter to a half a degree per hour. And then you get them up to the 37 and you're happy. Now, look, if a patient's 36.5, you don't need to do that. I think anything above 36, you could just let them rewarm to the 37. But if they're below that, then you should do machine-controlled rewarming. And that just means the brain has time to equilibrate to this new temperature rather than getting swelling and potential worsening of their neurostatus from rapid temperature changes. All right, that brings us to neuro stuff. The first thing to mention is seizures. These patients have a high propensity for seizures, and a lot of those seizures are non-convulsive, so you're not necessarily going to see it. So getting EEGs on these patients, continuous EEGs, as soon as possible is a great way to go. And all of these patients at some early point in their care should be on continuous EEG. This is another reason smaller centers should transfer, because even if you have a cath lab, then you look at your neuroservice and realize, yeah, we could do spot EEGs. We can't do continuous. Well, for a viable patient, that's not cool. They should be getting continuous EEG. That's another reason to transfer to a cardiac arrest center. If they don't seize and you don't have an EEG telling you they're seizing, then don't give them empiric seizure prophylaxis. So we're not treating these patients like we would a head bleed. On the other hand, if they had a seizure, and sometimes they'll have a frank convulsive seizure, then just treat it like your normal seizures, and then they should be put on seizure prophylaxis, something like a Keppra. The next issue is neuroprognostication. Now, there's no time zero neuroprognostication that works, meaning you have no idea if your patient at the time immediately post-ROSC or in those first few hours is going to walk out of the hospital neurologically intact or not. You don't have that capability. I see a lot of docs and a lot of nurses who say, their GCS is 3, their pupils are non-reactive. Why are we wasting all this time with all this work? They're not going to make it anyway. And that is not true. You do not have the ability at time zero to predict. In fact, you don't really have the ability to predict until the 48 to 72 hour mark. So do not look at a patient, look, they're just a rock. Their GCS is 3, they're not doing anything. Why are we wasting all this time being aggressive? That is a bad attitude, and it is not true by the evidence, and it is not true by my experience, so you have to stop. You have no ability to know who's walking out of the hospital or not. Now, some provisos of that. If you see a head CT that just has like complete gray fleece sweater, your gray sweatshirt, complete loss of gray-white differentiation, yes, there's an incredibly high chance that patient's going to have a poor neurologic outcome. Even on those, it's not worth it to say, all right, we'll just stop. There's no thing that lets you stop aggressive care in that first 24 hours. So just do everything as long as the patient was viable before their arrest. If you have a 95-year-old patient with severe dementia, what should happen is the doc, potentially you and the doc, talking to that patient's family and saying, there's really no hope here. We can't get them better than the severe dementia they already had, and their chance of walking out of the hospital, even with that neurostatus, is virtually zero. We should really consider about withdrawing care. But other than that, just go full court press right away. The really crappy thing about this, Candace, is if they do give less aggressive care, they turn out to be right. Not because they were right, but because their less aggressive care guaranteed the patient's not going to walk out. So it's a self-fulfilling prophecy, and they're all proud of themselves. See, I told you we shouldn't have wasted the time. Look, they didn't walk out. Yeah, of course they didn't. You left their blood pressure at a map of 50 and did nothing for them. They're not going to walk out from that. Don't let it be a self-fulfilling prophecy. Go full court press on these patients until they have their formal neuroprognostication. And up in the ICU, it gets even worse because then they're like, what's the 24-hour mark? They're like, they're not doing anything, so let's just pull back on how aggressive we are. They shouldn't be allowed to do that. The only way you get good outcomes in these post-arrest patients across the board is by forcing a protocolized neuroprognostication, not using the gestalt of the ICU doctor, the cardiac intensivist if they're an ECMO patient, but forcing them to go down a structured flowchart with neurology, doing these structured exams. And only if the flowchart says they don't have good prognosis, then you pull back care. Otherwise, you're not going to have the same rates as the really aggressive centers.
Yeah, and I think you're either all in or you're not, right? You need to decide that early. And your resources at the hospital, from a hospital administration level, they'll appreciate that. So you're not putting all the people aren't getting all the resources and all the expense for no reward. You need to know if you're all in or not.
Yeah. Now, that being said, if you have a patient who has some of the things early on that you're like, I don't know if this one's going to make it or not, I'm still going to do everything. What is incredibly valuable is an early call to the organ donation or organ procurement organization. And a lot of times what happens is these patients don't get called until right as the ICU is going to withdraw on them, and they might even be doing a brain death protocol. And now the organ procurement organization has lost a lot of time to actually plan out be there with the intensivist knowing what's going on. So if you have a patient who's, again, their CT scan looks like a gray sweatshirt, calling the organ procurement folks early and just letting them know, hey, look, we're still doing everything on this patient. They're going up to the ICU, but just have them on your radar is so valuable, and they would so appreciate that. And it doesn't hurt the patient's care. They're not allowed to intervene and say, hey, do this for the organ donation as you're still doing aggressive ICU care. It just means they could start planning and looking in on these patients and checking in. They might not even come to the hospital. They might just call every morning to the ICU and say, all right, what's the status on this patient? So that's something that's not done very often, but should be. We call too late on these patients. We call as we're doing a brain death protocol rather than calling early on.
Yeah, I agree. They'll tell you that too if you invite them to your center, right? They're going to tell you to call early, not late. We'd rather know more than less. And I would agree. We often call sometimes after we're talking about an extubation, a terminal extubation, and we've missed the boat there. So for us, we call on every post-arrest as soon as we get ROSC. The leader, actually, who's the operational leader for the day, does that. So it doesn't take away from the bedside nurse. Again, I have the opportunity to do that. But if not, it's got to be on the task list for the primary nurse to say, let me just give them a call. Telling them a little bit of information, you don't have to give them an hour's story, is worthwhile. Most of the places, most of Live On or whatever you're using, they have access to electronic health records, or they have a liaison in the hospital, and that person can serve to give that hour-long report that the bedside nurse can't do. But that's our standard now. It's part of the nursing standard of care is, did you notify Live On? And that's, I think, an opportunity globally that we could do differently.
Yeah, that's fantastic. And these organs are viable. People think, oh, it's a post-arrest organ, I wouldn't want those. No, when they actually looked at it in the right cardiac arrest setting, they're just as good as the organs that in a patient that didn't suffer an arrest. It's worth that. It's incredibly valuable to these poor people that are saved on the organ donation list. All right, Candace, we covered a lot. Is there anything you think I missed that you want to mention?
Ooh, what about a pupillometer?
Oh, wow. So yeah, this is something that came from the neuro ICUs and then has fallen down. It can be helpful, I think, for neuroprognostication, and potentially it could help diagnose non-convulsive status. But I haven't heard many EDs using this yet. Do you guys have access to this?
I have a neurocritical care intensivist that also does emergency medicine, and he likes a lot of fancy tools. And he asked me for one this year, and I really don't have enough reasons to say no.
Sure.
I told him he can create a protocol and we'll talk about it and bring me some dollars and cents.
There you go. All right. Anything else, Candace?
No, I think that's good for me.
All right. Well, let's stop there. So this has been a pretty Scott-heavy episode, but luckily next month we're going to have a very Candace-heavy episode. So don't worry. If that's who you came in to hear, you're going to hear a lot from her next month.
We could share.
All right. Sounds good. All right, Candace, say goodbye to the folks.
Bye.
Bye-bye. And that is a wrap.